I do want to thank the organizers, Greg and everyone, for inviting me and inviting us. I think this is really important for me and Dr. Langren for twofold. One is to be able to, speak to patients about myeloma and what the recent progresses are, but also to sort of highlight what we're doing here in South Florida. And my talk, I'm going to try to sort of be kind of in transition of what we're doing here and how we do it in Miami, along with sort of what's the best, what's the next and best going on. So I may be talking about Miami, but pretty much everything I say is really can be extrapolated to the whole country. So just an overview, I want to hit three major points here. First is how we treat newly diagnosed myeloma in Miami and the clinical benefit of the standard treatments we use. Number two is how do we incorporate new therapies into treatment, including the anti-CD38 monoclonal antibodies that we've heard about a lot today. And lastly, talk a little bit about CAR T therapies and bispecific therapies. So the treatment paradigm, we haven't really talked about this, but when patients first develop newly diagnosed myeloma, how do we treat it? And so I try to make this slide a basic slide, which is we start off with a combination therapy, usually including a proteasome inhibitor and an immunomodulatory drug. We usually typically treat for about 6 to 10 cycles or 6 to 10 months. Somewhere in between, after about 4 months, most of our patients who would be transplant eligible, or I like the term fit, or candidates for transplant, may get stem cell harvest midway. And then after about, like I said, at about 8 to 10 cycles after combination treatment, if the serum shows that a patient is in complete response, we would do a bone marrow biopsy and evaluate for minimal residual disease negativity that we've heard of a lot today. And based on that, usually we have a conversation and include the patient. It's a decision between the patient and the physician on whether we go straight to maintenance or we actually go through a high-dose melphalan and autologous transplant. So moving from doublets to triplets. So this is I wanted to put it in a little bit of a historical background. So novel therapies began to be approved in the mid-2000s, roughly, with the first ones being like thalidomide and bortezomib and then lenalidomide. Many patients, even in the 2010s, were still receiving doublets. And then we can see that very clearly here if we look at the Mayo SMART guidelines from 2013. At least for standard risk and even potentially for intermediate risk patients, it wasn't even recommended to get both a proteasome inhibitor and an immunomodulatory drug. And let me just take 2 steps back and not assume that everyone knows, but when I say a proteasome inhibitor, I mean drugs such as bortezomib or Velcade, or the newer ones like Kyprolis or carfilzomib. And the immunomodulatory drugs are like thalidomide, lenalidomide, pomalidomide. So triplets in relapsed refractory myeloma. It was around the 2010s where we started seeing data in the more refractory population on how 3 drugs were always better than 2 novel drugs. And here's just like one example using Kyprolis. Kyprolis was initially approved in 2012 by the FDA. And here is one of the important studies that actually showed adding Kyprolis or carfilzomib, same drug, to lenalidomide and dexamethasone made an impact. Both in progression-free survival, meaning the time it took for the myeloma to come back and how long patients lived. So moving doublets to triplets. So it wasn't really till 2017 when the results of this study called SWOG 0777 really reset the thermostat and satisfied kind of the whole field that 3 drugs were definitely better than 2 in the upfront setting. And this was published in the Lancet. And as you can see by the title, it compared bortezomib and lenalidomide and dexamethasone compared to just lenalidomide and dexamethasone. And here, again, these are Kaplan-Meier curves. They can be a little confusing looking at, but the take-home message was patients, if you received the 3 drugs compared to the 2 drugs, it took longer for the myeloma to come back. And also, you live longer if you got the 3 drugs compared to the 2 drugs. So, and a follow-up study, basically, it confirmed that with an average overall survival with the 3 drugs, meaning how long patients live, the median still hadn't been met, meaning that patients were still doing so well, not dying, that the average can't even be figured out just yet. So what comes after novel triplet combinations? With the establishment of novel triplet combinations, standard for newly diagnosed myeloma, really the focus has moved on to 3 important areas. A lot of these, I think all of these areas we already hit. So just to put it in perspective in this talk, we're talking about the establishment of minimal residual disease negativity as an important prognostic marker and early endpoint potential in clinical trials. Number 2, the development of novel, now from triplet to quadruplet based therapies, and the specific patient tailoring of the use of delayed high-dose melphalan with stem cell support, or as we know, with transplant. So MRD negativity. So these are just like, you can see many of these slides and basically, or many of these studies, and they all show the same, that in patients who reach or retain minimal residual disease negativity, overall do better than those who don't. And here are 2 meta-analyses. So what a meta-analysis, for those who may not know, is 2 groups, and one was Dr. Langren's group, but the other one, Dr. Munchi's group, where they looked through the literature, got all the data, and pooled kind of all the data together to see what the benefit of minimal residual disease negativity was. And in both cases, the important take-home message is MRD was probably like found as the most prognostic marker, both in terms of how long the myeloma stays away and how long a patient lives. So next, moving on, we had the arrival of the anti-CD38 monoclonal antibodies, the efficacy observed with anti-CD38 daratumumab, and its approval really revolutionized the way we treat myeloma currently. Shortly after, isatuximab was also approved with a similar mechanism of action. And with the new era of novel quadruplet-based therapies, really the efficacy observed with daratumumab and its approval revolutionized the treatments again of myeloma, and really opening up a conversation on how can we add this 4th drug to the upfront setting in the treatment of newly diagnosed multiple myeloma. The first studies that tested this added daratumumab to for us probably in this room, less well-known myeloma treatments. These are older treatments that are mostly currently used in Europe and in Asia, not so much in the United States, but it was like a proof of principle that adding daratumumab to these regimens actually helped patients live longer. And then the Griffin study was really important too, that Dr. Shah alluded to it. This was an important study because it added daratumumab to a relevant triplet combination that we do use in the United States. And here we can see the results. And again, the take-home message is basically the 4 drugs. So daratumumab plus Velcade, Revlimid, and dexamethasone, or lenalidomide and bortezomib and dexamethasone. Patients did better in terms of response rate. So given the results of the daratumumab VRD in newly diagnosed myeloma, really the next natural question is, can we expand on that? So can we expand on that by maybe changing out the Velcade or the bortezomib to a newer generation proteasome inhibitor, namely carfilzomib? So that gave rise to the Manhattan Project that was led by Dr. Langren in New York. And here in this study, you can see patients with newly diagnosed myeloma received 8 cycles of the 4 drugs, and patients did not receive default autologous transplant either. And when we look at the results, again, they see a MRD negativity. They saw an MRD negativity rate of 71%. So these MRD negativities, is basically a response that's one step even deeper than a complete response that we typically hear about CR. And speaking of functional cure, Dr. Morgan alluded to it also. And here, when we have 88% of the patients who have remained MRD negative for at least 1 year, meaning they have sustained MRD negativity, that's the kind of endpoint we're talking about as we get closer to a functional cure. There was another study, a similar study to the Manhattan. It's called the MASTER study, kind of similar idea. Really, the only difference was, or one of the major differences was this study incorporated high-dose melphalan with stem cell support and also was adaptive in how many cycles of consolidation with DARA-KRD patients receive. But really the point of this slide is, again, you have CR rates 86%, MRD negativity very high also. So role of early versus delayed transplant in this 3 to 4 drug era. The question is, well, if our drugs are getting so much better now, do we still need to use, high-dose melphalan? At least do we need to use it for every patient? And so that gave rise to the IFM 2009 study. This was a study that was conducted in France, and sort of its parallel sister arm was actually also being conducted at the same time, led by the Dana-Farber, and that we'll talk about in a second here. But long story short, the take-home message is patients got VRD, which again stands for bortezomib, lenalidomide, and dexamethasone. Both groups got that, but one group did not get the high-dose melphalan, and the other group got it. And so what happened? So as you can see, the results on the right, actually, the median progression-free survival was a little bit higher in those groups that got the high-dose melphalan, but patients did not live longer by getting autologous transplant. And so I think, it's kind of like you can always use the same arguments to kind of argue for or against high-dose melphalan and auto transplant. But really, one of the ways how I explain it is like at the end of the day, high-dose melphalan is just another therapy, a therapy that's fairly toxic, as those may know who needed it. And so instead of getting that therapy, you could potentially get some other therapy. And so in these trials that compare transplant, yes or no, it's like comparing a whole nother drug, yes or no. Well, maybe instead of getting, if you're on VRD, instead of getting transplant, maybe you can just get daratumumab or something else that is better tolerated. So there's different ways of approaching this, but the important key take home was that using current state-of-the-art, which I think at this point is with proteasome and an immunomodulatory drug, upfront combination, no study has really shown that patients live longer by receiving autologous transplant. And on a side note, this kind of advanced quickly here, let me see. And this actually, Dr. Richardson is going to actually present in the plenary session in a couple of weeks here at the annual oncology meeting about the results from the US kind of population of that study. So why wait until relapse for high-dose therapy and transplant anyway? So why are we talking about this so much? So high-dose melphalan, don't get me wrong, it really revolutionized the way myeloma was treated. It was pretty dismal before high-dose melphalan was being used. But with the introduction of novel therapies in the early 21st century, there've been incremental and even exponential improvement in different efficacy and how well drugs work. And in the current era where we have 3 and 4 drug novel combinations, really we ask the question, do we still need transplant for every patient? I personally think transplant and high-dose melphalan is an important tool for doctors to have in their toolbox, but I don't necessarily think that every patient really needs it. And so why are we talking about this? Well, there are toxicities involved in receiving the transplant. Centers have gotten much better, and sort of the acute mortality from infection is much less, but it's nevertheless is still there. And here are other things, more longer term toxicity, and that we're thinking about secondary cancers, including secondary like blood cancers. Here on the left, it was a study done by the Swedes that basically they showed that patients who develop second cancers, meaning the leukemias and the myelodysplastic syndrome, were more likely to be exposed to melphalan. And on the right, you can see a group down, our group led by Dr. Mora actually showed specific tattooing of like the DNA in those patients who were exposed to melphalan. And so where do we stand? So here we have the advanced study. This is a study that's led by the This is a study that's been led by Dr. Langren, and there's multiple sites that are including MD Anderson, where three drug VRD is compared to 3 drug KRD, which is compared to 4 drugs, the daratumumab KRD. And then response assessment is done. Then we look to see how patients are doing once they're assigned to the specific therapy arm. And then do they get, after stem cell harvest, you get a total of another 4 cycles of therapy on your respective arm. And next generation sequencing is done to look for minimal residual disease negativity. And if you're MRD positive, then we recommend high dose melphalan and transplant. If you're not, you go on to receive maintenance therapy. So this is what we're really focused on at Sylvester for newly diagnosed myeloma patients that are fit. And so what about in patients who wouldn't be, candidates for autologous transplant anyway? I mean, I think this study called the Maya study really revolutionized how we treat, this population, and time again that we see this combination of daratumumab with lenalidomide and dexamethasone has been not only associated with the myeloma not coming back, but also by living longer. And here again, these are the curves that show us that. So how do we do it in Miami? So more specifically, like I mentioned, about 90% of my patients are enrolled on this advanced study that I just presented. There's patients, of course, that don't want to be on a trial or for other reasons do not enroll on that. Or if we have concerns for neuropathy or we have concerns for cardiac history, may lead us to do one or the other. But really, we reserve off of a clinical trial, we may use KRD or daratumumab KRD when we are concerned about neuropathy. And I say that because bortezomib is associated with neuropathy, as many of you know. High-dose melphalan and transplant is really reserved for those patients who don't reach MRD negativity. We give indefinite maintenance with lenalidomide. That's been fairly well established at that frequency. Less fit patients receive daratumumab, lenalidomide, and dexamethasone. So it's Dara VRD that they receive. And if patients have significant cardiac problems, and we usually treat with, we try to avoid the carfilzomib and use bortezomib. So so everything I've been talking to you about so far has really been, newly diagnosed multiple myeloma. A lot of the relapse refractory myeloma drugs and the novel immunotherapies were already discussed, but just to summarize, I mean, look, this is the guidelines that doctors follow. Look how many different things you could potentially be used to treat. It's kind of all over the place. So that's how you have to really know. But I will focus on what the important thing is, like biggest news in 2021 and 2022 were really the approvals of both CAR T therapies. And here, again, CAR T therapy, this was discussed by Dr. Shah, but basically these are a drug called ide-cel and then cilta-cel. They're very similar and the preparation is a little similar. It's yet to be determined which one is better or not, although if you ask, I think a lot of doctors have their own biases, but I won't mention that. And again, the biggest thing we worry about with this is like neurotoxicity and this cytokine release syndrome. So moving on to bispecific. So what is CAR T? What is bispecific? They don't sound similar, but a lot of us, the discussions are about doing one or the other. Why are these two drugs being kind of compared? Well, the way I would actually think about it is on the left, we have, what a CAR T looks like. Basically, when you have your own T cells taken out and engineered in the lab, grown in the lab, and infused back into you to do the work against the myeloma cells. And so that's, as you probably remember from high school biology, that's doing something ex vivo, right? Not in the body, but ex vivo. So the next logical question is, instead of going through all that, is there a way to do that in the body? So cells don't have to be taken out and reinfused. And that's really what bispecific antibodies try to do. And that's what you can see on the right, where instead of re-engineering your own T cells, you're basically throwing an adapter. It's kind of like, think of a Lego adapter that ties the myeloma cell into the T cell. And that's what a bispecific antibody pretty much does. And that's why a lot of the side effects and a lot of the clinical benefit of them are actually similar to CAR T. And so here's a slide of like the pros and the cons. I mean, just to go through this quickly, I think the bispecifics do have a lot of pros. You don't have to wait for them. They're available to you. It's not your own cells don't have to be processed. That you don't have manufacturing problems as much because of that. And I think the biggest negative compared to CAR T is that you need, at least as of now, you need continuous therapy, right? It's not just a one-shot deal. And then if this is giving you a headache, it's supposed to. The point is there's all these bispecific antibodies. So it's pretty amazing how many we have. And some of them are subcutaneous, some of them are intravenous, some of them are once a week, some of them are every other week. But really the point is that if you look at that column that says ORR, that stands for overall response rate. Like how many patients myelomas are getting better with the specific drug. They're all about the same, right? Between 60 to 80%. So that's really what the take home is for that. Anyway, what about Sylvester? What are we doing? Well, we've opened many trials already. I think in the CAR T space, our first really important trial is going to be the CARTITUDE-5 that we're opening. And it really tests whether or not you need lenalidomide indefinitely, or you can get a one shot of a CAR T. So other important, we have a number of bispecifics. I heard a lot of people alluding to the tri-specific that, the myeloma crowd released, I guess, on Twitter. Dr. Langren is the PI on that study, actually. That's the Sanofi drug here. And then we have actually innate checkpoint inhibitors. So not only T cells, but, macrophages or those cells that kind of eat up bad things like bacteria and tumor cells. There's a way to try to activate them. So we have a study with that. And we have a study that's very similar to belantamab, which is the antibody drug conjugate, but the payload, the thing that does the work is not chemotherapy, but is actually a natural biological bacterial toxin from the Shiga bacteria or Shiga toxin. So in conclusions, treatment of newly diagnosed, like moving forward from novel triplet therapies to quadruplets, daratumumab, lenalidomide, and dexamethasone is showing unprecedented results for patients less fit. As therapies are improving, less people require early high-dose chemotherapy with transplant. Maintenance lenalidomide remains the gold standard in terms of maintenance therapy. Exciting time for targeted immunotherapies, both CAR T and bispecific antibodies are showing great results. And moving forward, I think strategies will involve or aim to incorporate immunotherapies to even more upfront settings and even possibly abrogate like the need for autologous transplant in the near future as studies are done. And so I think we're in good shape. Myeloma is doing well. I'll transition now for maybe a little PR for our program here at Sylvester. So we have our beautiful campus in downtown Miami. In the 1 year Dr. Langer mentioned, we've grown to 6 physicians. We actually are very pro-patient. We guarantee visits within a week of getting a call. Patients don't have to wait for months like some other groups. And what's really nice is that there's a strong satellite network. And so Dr. Langren and I also see patients in Coral Gables, which is the Lennar main campus, University of Miami main campus area. And Dr. Hoffman also sees patients on the north suburbs in Deerfield, which is close to where we are right now. And those are where the myeloma doctors are from our program. But there's very many more sites where patients can get chemotherapy. And so we have a lot of patients where they may have to travel a little while to get to us, but most of their therapy is actually maybe closer to their home at the various, at the various sites that are actually available. So this is our program. I wanted to, highlight the most important things, as was already mentioned, is really you guys and all of you. It's always a team. I think when a patient of mine is very happy with the result, I always say it takes both of us. It really does. And in particular with clinical trials, when I came from the NIH is 99% of my patients were clinical trials. if we didn't have you guys participating in trials, I wouldn't have had a job there. So thank you for all you do, and I highly encourage continuing to do that. And I just want to thank you for your attention.